and welcome to this evening's special report to investigate how cholera is affecting livelihoods in the Democratic Republic of Congo. Over the last few months here at EDL News, we have followed the cholera crisis in the DRC, which accounts for 27% of all cholera-related deaths globally. As well as a humanitarian issue, cholera is posing a serious threat to the ability of the DRC's economy to recover from over 20 years of civil war and immense corruption due to its debilitating impact on people's ability to earn a living. This evening, we will hear from a number of experts and DRC nationals to further consider the management response of the national and international community, the geographical disparities between rural and urban affected regions, and investigate the relationship between outbreaks and proximity to water sources and how this impacts response strategy. First up in our special report, we hear from Neva Mutumbo, a community leader in the Equatorial Province.
I live here in Mbandaka in Equatorial Province, the province most affected by the 2011 cholera outbreak due to its proximity to the Congo River. Fishermen travel down the river from the eastern lakes at the end of the dry season, spreading the disease, with refugee camps on the water's edge containing some of the country's 2.7 million internally displaced persons and refugees, worsening the situation. The country is recovering from conflict that broke out in the 1990s, which destroyed much of the sanitation infrastructure of the country. So the DRC has struggled to cope with diseases. And since then, the country has consistently been in the top 5 countries affected by cholera in the world. We are lucky in Mbandaka as we have a cholera treatment centre funded by UNICEF, the World Health Organization and Oxfam, which provides free treatment and food to those that are ill. Since April, there have been 681 reported cases and 1 death just in this region. However, the centre is running out of food rations, which is slowing down patients' recovery. One of my friends at the centre developed the disease due to the latrine his family shares with his infected neighbour, so the improved sanitation infrastructure here is not necessarily adequate. Some people in more rural areas have actually developed cholera whilst in hospital, as some hospitals are still sourcing dirty water from the Congo River, and there are other reports of the disease spreading easily through schools due to poor hygiene. The organisation in this region are trying to raise public awareness of the disease and educate both the young and old to wash their hands before they eat, trying to emphasise the prevention of the disease. However, many people are already educated, but just have little choice, as purification tablets cost 50 francs each, and firewood to boil water is expensive. Most of the new wells here also require a maintenance fee, and many have long queues, so it is more convenient for people to get water from the river.
Next up, we're going live to the Democratic Republic of Congo to our man on the ground, Oliver Hazelden, to find out what's really going on. Over to Oliver.
Thank you, Connie. I'm out here in the Democratic Republic of the Congo, which has experienced some of the highest incidences of cholera in sub-Saharan Africa. I'm out here trying to understand the impact on livelihoods of those who suffer from it. As it stands today, about 50 million Congolese do not have access to safe water. About 80 to 90% of the population have not had any improved sanitation. A majority of people out here are aware that insufficient hygiene and sanitation levels are responsible for cholera, but little has been done to improve their situation. The focus of my report out here in the eastern provinces of the Congo will be looking at the worst affected groups, which have been fishermen and squatters. But that does not mean that subsistence farmers over there have not been greatly affected. In a recent study into how cholera affects their people's livelihoods, 96.6% of those living in rural areas and 97.4% of those living in urban areas said that the impact of cholera has some impact on their livelihoods. This is what can be seen around here in the fishing camps of Lake Muru, in an area I am now, where only 12.5% of the population are employed in the formal sector, meaning that the workers out here have few rights, and so the impact of cholera on their livelihoods is exacerbated. Also, out in the Congo, there is a massive stigma against those who get cholera, especially from people within the rural communities. And this stigma deters people from accepting any sort of treatment, so help from the UN in forms of vaccines and oral rehydration therapy has been reduced. I recently spoke to a fisherman who professed that he was reluctant to take his work colleague to hospital for fear that he would have to pay for his treatment. Cholera can affect anyone of working age, or anyone actually, especially people of working age. And because these people are most likely to be affected, the impact on family lives is increased because it's often down to the younger children who have to look after them. The impact on the younger people means that they do not have access to education because they're looking after their parents who have been affected by the disease. The impact of cholera is greatest on the socially marginalised groups such as fishermen, peasant farmers and refugees. And the work of Van Buren describes the poverty complex that can be witnessed here, where poor living conditions, frequent migration and disrupted social structures catalyse the spread of cholera, increasing the impact on people's livelihoods. Thank you for listening to my special report on cholera. I shall now pass back to Connie in the studio. Connie, over to you.
Thank you, Oliver. Here in the studio we have Connie to represent We Are Water Foundation and Jacob, our in-house water expert. So Connie, tell us about your organisation.
We're an NGO working in the southern and eastern districts of the DRC to improve access to drinking water, hygiene and sanitation in rural communities where cholera is endemic. We are running 25 projects in 18 countries, and we have less than 29% of rural inhabitants have access to drinking water in the Congo, and less than 31% have adequate sanitation facilities. We are working on improving these statistics.
Shocking statistics. Super NGOs like yours often fail to take into account local, cultural and social needs of individual citizens, as well as environmental conditions that smaller NGOs such as Foundation Veolia, who work in just one region, take into account.
That is a valid point, but we have a large budget and we have the ability to work all across the country, and these statistics show we're making real progress to people's livelihoods.
Could you name an example of that?
Sure, one of our biggest successes is getting 80% of our households to use and able to maintain latrines, which is an improved sanitation system.
80% sounds great, albeit very broad. Are you sure you haven't excluded or marginalised anyone? And how do you plan to monitor this statistic? What's the distance involved for someone to be able to use it? Is it 50, 100, 500 metres?
True, at our scale we can't monitor all of the latrines, but we have helped 200,000 people since the organisation began.
But cholera is often underreported due to fears of negative impact on travel and trade, and the World Health Organization analysis suggests that in Bangladesh alone as many as 90,000 additional cases in the country may have been attributed to other diseases. Do you think this is the case in the Congo?
I imagine it's also underreported due to the stigmatisation around women and waterborne diseases. We need to focus on...
I'm going to have to stop you there, but this is definitely a conversation that needs to continue. Thank you for your insights, and thank you to everyone we've heard from this evening. I'm looking forward to further updates. We'd love to hear from you at home, so please use the Twitter hashtag EDL Livelihoods to continue the discussion